devote to this particular issue, the electrocardiogram, and particularly the abnormal electrocardiographic pattern consisting of inverted wave in lateral leads, or mostly inferior in the lateral leads. I appreciate this kind of approach that Michael and the other people actually suggested for this topic, because this is very practical. And according to the location of the inverted wave, we should have a different approach. And so the main message for this lecture, 10-minute lecture, is that in front of one electrocardiogram, such as this one shown here, showing clearly abnormal inverted wave in the lateral, what is inferior and lateral leads, the main message is to look for underlying cardiac disease. Why we suggest this? Where is the evidence? The evidence actually is not novel. Okay, this is the prevalence. Let's go to the next one. The evidence is not novel. This is about 20 years ago, where we examined for the first time a large population of the athletes with the electrocardiograms. And we really found in our selected population cardiovascular diseases, mostly in individuals and in athletes that showed inverted wave with the inferior and the lateral leads. This finding was subsequently confirmed by Sanjay and the team. These are just one of the results of their investigation. In case of inferior and lateral T waves, they found people with hypertrophic cardiomyopathy, while in people with the anterior inverted T wave, they had the same experience we had, and no one had evidence of hypertrophic cardiomyopathy. So, the first message is that we should look for underlying cardiac disease, and mostly cardiomyopathies, and mostly hypertrophic cardiomyopathy. How should we look for underlying cardiac disease? This is one of the Maidstone paper from Schnell suggesting that echo is not enough. Here, in a population of 155 individuals with the inverted wave, by echo they found 24% of diagnosis. With the cardiac MRI, they were able to add plus 15% of diagnosis with mostly, in most cases, was hypertrophic cardiomyopathy. So, diagnosis of underlying cardiac disease is possible and should be done by imaging testing. Echocardiography is the first step, but it's not enough. And in most cases, you should have cardiac MRI, which has the potential to increase the diagnostic capability and your diagnostic capability to give you an idea of what you are looking for. Why cardiac MRI? This is, someone already saw these slides, but I like these slides. Please consider this case, young athlete, asymptomatic, so mild segmental left ventricular hypertrophy here in this particular area at the junction with the right ventricle, which was a questionable evidence for hypertrophic cardiomyopathy. However, the presence of late gadolinium enhancement in the same area reinforced the suspicion for hypertrophic cardiomyopathy. And the cardiac MRI can give you not only exact definition of hypertrophy, extension, segments that are involved, but also gives you the additional information, which is unique information that show the presence and patterns of late gadolinium enhancement. And now there is a consensus that the presence of gadolinium enhancement, and particularly the extent of gadolinium enhancement in excess than 15% of the overall left ventricular mass may have a clinical relevance. I'm telling this because at the moment, in the guidelines, in the risk stratification, CMR with the gadolinium assessment is still not present, but there is a convincing evidence and increasing evidence that this is one of the potential determinants for better stratify the risk in hypertrophic cardiomyopathy. And so the first learning point today is that in case of a lateral inferior lateral T-wave inversion, we should have an extensive investigation searching for underlying cardiomyopathies, usually hypertrophic cardiomyopathy, and as I said more times, cardiac MRI can be utilized. In addition to cardiac MRI, family screening, at least EKG and maybe echo, while exercise testing and the Holter monitoring are more useful for risk stratification, much more than for diagnosis. Finally, gene test at this time in the time is relatively less useful for diagnosis of hypertrophic cardiomyopathy. There is a wonderful paper published 2 years ago by Sanjay and team suggesting that the yield of genetic testing in sporadic cases is probably 10% or less. So that means that in clinical practice should not be advocated. First point. The second point is, what to do when we cannot find any evidence for hypertrophic cardiomyopathy or any other cardiomyopathy. This is relevant to know that electrocardiogram can be abnormal even before on time that development of the phenotypic expression of the disease. So abnormal EKG can precede by years the presence of hypertrophy. And just a very short example, this is a soccer player, aged 28, horrible EKG, in the presence of completely normal left ventricular morphology, structure, and function. The same, obviously, we were looking as a med, we were crazy for this. How this abnormal EKG can be possible in the absence of anything, no symptoms, no family history, nothing abnormal on the cardiac structure. But a few years, just 3 years later, in the EKG was even worse. So finally, we were able to identify here the development of hypertrophy, which mostly affects the apex. One more example. This was an Olympic swimmers that was at the time of the first evaluation. What we found here was just an inverted T wave in VL, just here. Maybe diphasic in standard Leads 1. You may guess about this diphasic T wave in V2, but I just want to mention this. And what about the structure? That was the structure at the time of 1995. Here, left ventricular cavity was 50 millimeters. Maximum wall thickness was 12 millimeters. So we were not concerned. We say morphology is fine, structure is fine, no symptoms, Olympic swimmers, medalists several times. Okay, but eventually, just 8 years, because we were following these guys each single year. Well, I can show you, this is after 8 years. You can see by echo, you can imagine by echo that here there is an hypertrophy, and the cardiac MRI actually confirmed that here anterior and the lateral free wall reached 15 millimeters. There is a clear increase in wall thickness, here you can see, but at the same time also please See the cavity sides. Here is a very regular. The geometry and the shape is normal, and here the shape is become abnormal. So diagnosis of ACM was confirmed by genetic testing by this guy was around, he had 13 cardiologist consultants, including British people. Everyone eventually confirmed the presence of hypertrophic cardiomyopathy. So this is, you already seen, we had the evidence that people with this abnormal EKG after about a reasonable long period may develop a phenotypic expression of the disease, including events. And so this suggests that people with abnormal EKG, particularly this kind of abnormal EKG, should be followed serially. And let me finish with this paper, wonderful paper, which actually suggests that the people at the age when they were adolescent, they actually found some people that were considered normal, and eventually, over time, they develop evidence for cardiomyopathies. Why? Because there was a time span of average more than 6 years from this evaluation and the evidence of the disease, from the time of the screening and the time of the events, which suggests the main message of this paper is screening once in adolescent time is not enough. It's not enough because cardiomyopathies, particularly hypertrophic cardiomyopathy, usually develop over adolescence or in the young adult age. And so we need serial evaluation. And so the second learning point is that in case of this abnormal EKG, serial evaluation and serial follow-up is needed because you can see in here, in 2 or 3 or 4 or 10 years, something that is not present at the first evaluation. Although there is a subset of these individuals which actually over time, including a long-term follow-up, remain with abnormal EKG and they do not develop a phenotypic expression of the disease. They do not develop hypertrophy. These individuals with abnormal EKG seems to have a benign clinical outcome. And that's it, okay?